Hi. Welcome to the Midwives Reality Show.ke. My name is Evalyne Gewa.
I'm Bearing Guru.
Back again with a very, very interesting topic.
And baby?
Nana.
Today
we are doing
induction of labor.
Why do people fear induction?
Wow.
Induction of labor. Sorry, Mary. Induction of labor is feared by mothers here that we are going to induce you. No. Why?
I think just maybe they don't clearly understand what is induction.
I think it's good time we tell you what induction is so that you understand. But before we start, kindly subscribe, share, comment. For those who are joining for the first time, welcome. Feel at home. We don't take it for granted. We thank you for being here. Yes. Mary, say something.
And for the returning subscribers, I don't know whether I sing for you a love song.
You're the best.
Or what do I say?
You're the best.
You're the best.
Take us to 1,000 subscribers because we can.
We can.
You
gang. Let's get moving.
Exactly.
1,000 is not too much.
We are halfway.
Yeah.
We are halfway.
Let's hit it.
Yeah. So guys, today, without wasting much time, Mary, tell us what you have for us. I can see you have some few things here.
Wow.
Yeah.
I want just to say this is our baby Nana.
Yeah, baby will be delivered.
And our baby today, baby Nana will be taken back to the womb.
Yeah.
And this is our womb.
Yeah.
This one.
This is our uterus.
This is our uterus and this is our placenta.
Yeah.
Okay. So baby Nana goes back to the
womb.
To the womb.
Bye, baby Nana.
Bye. You'll be born through Inda. We'll do induction.
Will you induce your mother?
Mommy will have induction done for you to be born again.
Yeah. So baby Nana is in the uterus. Show guys.
Baby Nana in the uterus.
Yeah.
Back to the uterus.
Yeah. So baby is in the uterus.
Baby Nana wants to be born before time.
Your cervix is loose.
The cervix is opening.
Yeah. So guys, before we start, we're just going to define what induction is, and then we'll flow, and Mary will tell us when time comes for us to deliver baby Nana. Now, induction of labor. What is induction? So that people understand, and it is not something so bad. Yeah.
Induction of labor. Induction of labor, just like the name.
Yeah.
Is introducing you into labor mode.
It's like introducing you into pain.
No, introducing you into labor mode.
Yeah, it's prompting the uterus to start contracting. Yeah.
As in, it didn't start naturally.
Yeah. But it was prompted
by our actions.
Yeah. Something prompted it to
contract.
To start contracting before the uterus contracts on its own.
Yeah, naturally.
Yeah.
So there are many ways of doing this.
Yeah. We can do the methods used for.
Methods or who should have induction?
Not everybody can be induced, guys. Not everybody can be induced. And by saying not everybody can be induced, I mean the ones who can be induced are as follows. The first one, if you have gone more than 40 weeks and 42 weeks and above.
No, 40
plus 2 weeks.
Yeah, you need an induction.
Yeah.
Or what we are trying to say, if you have post date.
Yeah.
Like our due date is on 22.
Yeah.
You can have.
Yeah.
But currently there is a research that is showing that if induction is done earlier, 39 weeks.
Yeah.
It has
still okay.
It has a high success rate.
Yeah.
Than done at 41, 42.
Okay.
Yeah. So these are discussions between you and your care provider.
Yeah.
But from 38 to 42, depending with the reason,
it is still allowed.
It's still allowed.
Exactly.
Yeah.
Don't induce a premature baby, not unless
There's an
indication. Yes. So, who else is supposed to be induced?
Somebody else who is supposed to be induced
Yeah.
if the baby is not growing well.
Yeah.
As per
gestation. What do we call that? Intrauterine growth restriction. Yeah.
So this is when the baby is not growing well, as in is not gaining weight.
Yeah.
As per the gestation.
Meaning, if I'm 32 weeks,
it shows like I'm 28.
It is smaller than 32 weeks.
Yes.
And that can come because of some reasons.
Like probably if you have something like hypertension.
Exactly.
It can cause.
Yeah.
Another thing that would make you get induced is if you have hypertension, diabetes.
Yeah.
And diabetes, for hypertension, it may cause that growth restriction.
But for diabetes?
For diabetes, you get babies who are big.
For their gestation.
It
is the other way.
Yes. Yeah. So, either of them you may get induced.
Yeah.
For diabetes, you induce at 38 to 39 weeks.
Yeah.
To avoid this baby overgrowing.
Yeah. That is
becoming
mothers who have issues of hypertension, diabetes.
Yeah.
So that's a point on its own.
So, yeah.
Yeah. So how about the premature rupture of membranes?
Yeah, premature rupture of membranes.
Yeah.
Can cause.
Yeah, can be an indication for.
Yeah, so that to avoid
induction.
Getting
the infections. Yeah.
Remember when my membranes break?
Yeah.
There is a continuous.
There's a communication between
the
outside
world
and the uterus.
So yeah. You can get some infection.
Yeah.
Just before the labor kicks in.
Yeah.
Naturally, because you see, breaking of water sometimes it may mean
labor.
Sign of labor.
Yeah.
You go to the hospital. You're given a few hours.
Yeah.
If the labor doesn't kick in.
Yeah.
Within the stipulated, that is why we say it's always good to go to the hospital, know their policy.
Yeah. Get to know what happens.
What happens in that institution.
Yeah.
Yeah, because it's always good before 24 hours clocks. At least let the labor be initiated.
Yeah.
And you can only initiate labor through induction
of labor.
Yes.
You've talked about the hospital policy. I wanted to put something as a point. Don't compare hospitals. Every hospital has its own policy on induction. Don't say, this is what was done for me the other time in a such and such a hospital. Why are you not doing this one here? Every hospital has its own protocols and policies, and please respect it, because when they were setting, they had something in mind. Okay? Yeah. So there's another point about
even maternal requests.
Yes.
I've reached 39 weeks.
Yeah.
I live far.
Yeah.
And my desired institution to deliver is probably I'm in the central part of Kenya.
Yeah.
And I want to deliver in the city.
So you want to set your birthday for yourself?
I want to set I want the baby to share with me my birthday. And since my baby is already mature, there's nothing wrong. The doctor will do what we call bishop's call. Yeah. And will advise me, or the midwife will do the bishop's call and then advise me whether it's okay.
I want to put an input on that. Yeah. That is if you are very, very sure about your dates. Do not say your baby is mature and you're not even very sure about how the dates. You might end up inducing a very premature baby. If you are very sure with your dates, then that's okay. If you're not sure, don't. Sure.
Others, you'll find like, I wouldn't say it's still maternal request. There is a reason. Yeah. Maybe I delivered the first one before I got to the hospital. Yeah. I don't want a repeat of the same. So when I near my dates,
you just rush to the hospital early enough.
You go early enough. Yeah. And you get induced. Yeah. Since probably you are the type who get what we call precipitate labor. Yeah.
Labor that comes so fast.
Yeah. So that is why you need to be near a hospital. Yeah. for you to be safe.
Exactly.
Not everyone who can have induction, guys.
There's a point about intrauterine fetal death.
Oh yeah.
Remember, intrauterine fetal death is something that is not good. Losing a baby when in the uterus. It might be because of so many things which we are not going to outline here. But if it happens, the only way that baby can come out. Remember, some of them lose their babies when it is not yet time for delivery.
Sure.
And that cervix is still not ripe. So not unless you induce that baby will stay in that uterus. So induction is indicated for intrauterine fetal death. Yeah, so it's not a pleasant thing to discuss, but yeah, just know it's
good to know.
Exactly. Yeah, so you were saying that not everybody is indicated for induction.
For sure.
Now, who is this who cannot be induced?
For those mothers who have what we call placenta previa.
Okay.
We discussed placenta previa
at length. Yeah.
During our previous
the first videos.
The first videos.
Yeah.
But just to repeat, for the benefit of that one who has not watched.
And the benefit of the one who has just joined us. Yeah.
So, assuming this is our placenta here.
Yeah.
Instead of the placenta being up here, like ours where it is.
Yeah.
This placenta comes and closes the cervix. This is our cervix.
Yeah.
Comes here.
And attaches itself.
Around the cervical region.
Yeah. And closes.
So, you see, instead of seeing baby Nana,
you're seeing the placenta. Yeah.
So these are candidates who cannot
be induced.
Yeah. Having a low-lying placenta. That is what we call it in layman's
Ideally, the placenta is supposed to implant.
It should be like this.
On top, eh?
On top.
Yeah, on top.
Again, another group that should not have labor induced is if the baby is bigger than
the mother's outlet.
Yeah. Not necessarily the baby is so big, like 4 kgs.
Yeah.
It can be a baby of 2.8, but cannot fit on the mother's pelvic brim.
So it is the baby's size in relation to the mother's pelvis.
Yeah, what we call
CPD.
Yeah, cephalopelvic disproportion.
Yeah.
Yeah. So another thing is when the baby is sorry viewers. Baby is now transverse.
Okay.
Staying across the tummy.
Yes.
Is like this in the womb.
Yeah, you can't induce such a position.
You can't reduce this position.
Because the diameter is very big.
Yeah, the baby cannot
come down. Yeah. Maybe we can show our viewers which is the ideal or the correct position for induction on the baby.
The correct position for induction is when the baby is facing downwards.
Yeah.
And the head, you see the face of baby Nana?
Yeah.
Is facing my
pelvis.
My
back. Yeah.
Because even when it is like this, when baby Nana lies on my back.
Yes.
This is what we call occipito-posterior position.
Yeah, or PP. Yeah.
Before this baby turns to face this way, sometimes it may take long and induction may fail.
Yeah.
But this is not a full. This one is not a full contraindication.
No, this one can deliver.
But a point to note, it may take longer than
the normal time.
The normal time.
Yeah. So this is the correct position of a baby.
Yes. Another thing is if you previously delivered by
a cesarean section. Yeah.
So you can't be induced.
Yeah, we can't induce a scar.
Why?
Because there's a risk of rupture.
Yeah.
There's a risk of rupture of the uterus.
Yeah, you can get strong contractions. You don't know how the scar healed.
Yeah.
And it can give way.
It can give way. Yeah, so having known that, what about the patients who have vaginal warts?
Yeah, guys, you know what?
Yeah.
There's small growth found along the vagina area.
And the herpes.
Yeah.
Yeah.
And sometimes why we don't induce or we don't encourage them to have normal delivery is that warts tend to bleed a lot.
Yeah.
And also can pass infection to the
baby's eyes. Yeah.
Yeah.
So it's a contraindication for induction. If you must be induced and you have them, treatment first. That's true. You need to be treated first. Okay, having known that, any addition, guys, about who is not supposed to be induced? And what's your experience about induction? Maybe you can be telling us. We are still on the Midwives reality show. .ke. Yes, we are still on induction of labor. And induction is not something you're supposed to fear. It is just a way of initiating pain or labor because it has not come on its own.
It's usually gradual.
Yeah. And some mothers say induction is more painful than normal onset of pain.
Induction or normal labor, they are both painful.
They are both painful. And guys, you're supposed to understand that labor comes with pain. If you need painless labor, then there has to be a pain relief or pain management.
But labor is painful.
Labor is painful.
Induction of what it does, it comes gradually.
Yeah. Yeah, so
there are many methods of
induction. Yeah.
One is use of drugs.
The use of drugs.
Yes.
Can we call them hormones?
Yes.
Are they?
Yes. They are hormones.
Yeah.
Prostaglandin hormone.
Yeah.
Which is responsible to bring in
labor.
Yeah.
So it comes in different ways or different forms.
It can be a gel.
It can be a gel. It can be a pessary. Yeah, it can be a pessary for inserting. Others even
take them orally.
You can take them orally.
Yeah, just to mention.
Yeah.
You go to some hospital.
Yeah.
They'll use what we call majority of the hospitals in Kenya, like the government settings. They use what we call cytotec.
Misoprostol.
Or misoprostol.
Yes.
Cytotec, you take like 25 to 50 micrograms.
Yeah.
But guys, I'm not saying this you do at home.
Don't.
We
do not do this at home. They can't even be sold for in the chemist.
So don't do this at home. It's always good to do under guideline and under supervision.
Exactly, because it's a dangerous drug. It can bring a lot of harm.
So we use misoprostol. Yeah. You can depending with whichever facility you go to. Yeah. They can decide just to dissolve and give you
with the water.
Yeah. Like they dissolve it in water and they give you a certain amount as diluted.
Like a 200 micrograms tablet, and then you dissolve in water. You'll be taking after every like an hour or two, depending on the doctor.
Another thing, we can use the gradine tablets. Yeah. This one, it is inserted 4 to 8 hours.
But gladine is just a trade name. It's just a company name. It is a prostaglandin. They come in very many forms, and they come in so many names depending with the company.
So you can be inserted through your vagina. And then it dissolves. Probably you're told to rest for a few minutes. And then you may start clamping or not. Maybe to wait for the next dose.
Yeah, one thing they should understand is, our viewers should understand, is induction is a process. And it's a process that might even take up to 24 hours.
Sure.
Now, take for instance, I've come in labor ward today. I'm not in labor, but I'm coming for induction of labor. Now, I'm given the first prostaglandin at 6 p.m. I'm supposed to rest for that 1 hour, because if I walk, I will dislodge the drug. And then I'll be given an interval of 6 to 8 hours, depending with the doctor, so that I can be checked again. If I'm not in labor, the same procedure will be followed. Some doctors give only 2, others give 3, but a maximum is 3. So if you take that, it has taken you to 24 hours. So it's a process. At an
interval of
8 hours, yeah.
And guys, when we are doing all this,
yeah,
there's what we call bishop's call. Maybe just before you're sent to the ward,
yeah,
if it's not like a dire requirement at that point, somebody will do a bishop. Just do a vaginal examination.
yeah,
check on the cervix.
Yeah,
How soft.
Yeah,
How long.
Yeah,
And whether it has started opening and how thin or thick the cervix is. Then you get a score. That is what we call the bishop's score, and the consistency of that cervix.
And there are times when a mother has come for induction of labor only to check and find she's in labor and she doesn't know. Are there times someone gets silent labor?
Yeah.
Which can be very good,
Yeah.
Because it's painless.
Yeah, but also, it also depends with your pain threshold.
Exactly.
Yeah? Maybe you've been just getting some mild cramps. To you, it feels mild, and probably to me,
it's not mild. Yeah. So it depends with the threshold. Yes. And then another thing before we move to the next method, before I start induction, and this one goes to the health provider, it is good to ensure that both the mother and the baby are safe for the induction. What do I mean? For the mother, before you start induction, ensure that her vital signs are okay. Assess the mother well. And for the baby, ensure that you've checked on the heart rate of the baby. So that you don't induce a baby who's already distressed. Yeah, when you induce a distressed baby,
you'll get into more trouble.
More distress. So it's good to ensure safety of the mother and the baby first before induction. Yeah, so Mary, the next method.
The next method.
Yeah.
It's called mechanical method.
Mechanical.
Just like the name goes.
Yeah.
You're using no drug.
Yeah.
You are using
mechanical method.
Yes.
What?
It's commonly used for IUFDs.
IUFD meaning intrauterine fetal deaths. Yeah.
But also, even in live babies, it can be used.
Yeah.
Actually, long time before the gradines,
before the prostaglandin
tablets were well researched.
Yeah.
That was the method that we ever used to use.
Yeah.
Those days.
Yeah.
There is the urinary catheter.
Size 16.
Yeah, there is a urinary catheter. It is inserted through your vagina.
So this is the cervix. The cervix is here. Maybe I can hold you so that you can point to them.
Assuming my pen is a catheter. It's now this is
the cervix.
The cervix.
Yeah.
This is the vagina, my hand.
Yeah.
So it's put through the vagina to the cervix.
Yeah.
You come and put it inside there.
Yeah.
That catheter. Then it normally has somewhere you can balloon. You can put like some water.
Yeah, just the normal urinary catheter.
Yeah.
Yeah.
Then you pull this catheter. Just to now here inside it balloons. So that it does not come out.
Yeah.
So then you put a good traction. It's a labor.
Yeah.
So it is elastic. So if you put a traction like this on the catheter, then the traction forces the cervix to open mechanically.
Exactly.
It forces it to thin.
Mechanically meaning manually. Without any drag.
Yeah.
Yeah.
And after it pushes after the because of that traction.
Yeah.
It forces the cervix to open or the cervix to thin out.
Yeah.
And once the cervix thins out,
it opens.
Naturally, you produce your prostaglandin hormone naturally.
Yeah.
And now that registers that you're going into labor and the contraction may start picking up.
So Mary, you want to tell me induction of labor, once you have introduced the prostaglandin, it is usually for ripening the cervix, for softening. And then once the cervix are softened, the body picks up
from there.
It picks up from there so that it can start producing its own prostaglandins.
By the way, even with the tablet, the tablet also softens. Then the body is able to pick.
It's like boosting the body so that it can
hygienating.
What is it called?
It's like hygienating the body.
Exactly.
Yeah.
So the body picks up so that the induction, the labor peaks. Yeah.
So
it is interesting.
Very interesting.
Yeah.
That is one method. Okay. No, those are two, drug and mechanical.
Yeah.
Now when the catheter falls off, that balloon is out.
Yeah, meaning the cervix is open.
The cervix is open.
Yes.
From there, there's another called amniocentesis.
Yeah. Or amniotomy.
Yeah. Amniotomy, this will happen with somebody with a good bishop score.
Yeah.
At least where the cervix is a bit open.
Yeah, soft.
Yeah. Then you can do a vaginal exam.
And rupture the waters. The waters are the membranes. The bag of waters where the baby is sleeping. Yes. You just puncture it and then the water comes out.
And it's not painful, guys. It's not painful. So once you rupture the water or break the membranes, now the head lies on the cervix. On the cervix directly. Instead of the head floating. So it lies on the cervix. And applies pressure on the cervix. That makes it thinner. Again, once it is thinning,
prostaglandins are more produced
by your body. Okay. And once it is more produced, the labor continues. The labor now picks up nicely. Okay.
And if it's not picking up nicely, there's a process we call augmentation, whereby we help the body. We supplement the body.
And you know that is what most people call induction.
That is not induction. That is not induction.
The drip is not induction.
Induction is the initiating part. Starting.
Jump starting new.
Exactly. And once you have jump started you, then we give you
that is like a boost.
So that you can help you with the contractions.
So I think the last one. The last one is called membrane sweep.
A membrane sweep.
Membrane sweep is, you can see, guys, our cervix here. It's open. You can see?
It's clear.
So for membrane sweep, you still also need a soft cervix. You need a cervix which is open. That means you have a good bishop score.
So you need to have a good access to?
You need access so that I'll come as I do my vaginal examination. And guys, I've been repeating about vaginal examination. I think the next video we'll do
a vaginal examination.
We'll do a vaginal examination.
A demonstration
so that even how people say it is painful, we show you how to rest and
we show you how to make it easy for you. It should not be painful. So through your vagina to the cervix. My the
2 fingers
is here.
So I'll put one finger or both of them. I'll scroll round the cervix.
And it is uncomfortable.
This is uncomfortable.
That one is uncomfortable.
This is uncomfortable. But it really helps. So all what I'm trying is like now to make your body produce more prostaglandins by itself. And by the time I finish, most of the times you get a tightening on your abdomen.
Exactly.
And that way gradually picks to labor.
And I have noted when you're doing a membrane sweep, there's a lot of show at that time. What happens?
Of course, because you are, what is show? It's
the shading.
It's the shading of
the
cork that corks there.
Exactly.
Now you have already gone to the cervix. So that is how you end up getting the show. So guys, those are our 4 types of
methods of induction.
So drip is not
On induction, it is just augmentation.
That is
Which one worked for you? Which one worked for you? Mary, I think it is good we take them briefly on what they should do. Our viewers should understand on induction. As I said earlier, you're supposed to wait for 1 hour. Okay, some preparations are like, before induction, you're supposed to have your bladder empty. Yeah.
Once you enter the bladder,
you're empty.
Okay, even before we get to the induction itself, the first thing we have verified mother and baby are fit,
safe,
are fit for
the induction. Yeah.
Okay. So if they are fit for induction, the next step is to be explained for. Remember, guys, we always say you have your role,
and I have mine.
I have my role. So before I do anything on you guys,
I explain to you.
I should explain.
Yeah.
And if I don't explain, kindly ask.
So Mary, you want to tell me it's like I'm obtaining consent to induce you? Yeah. And I think there are hospitals who sign consent for induction.
There are some hospitals actually who sign paper
for induction.
Quite a good number in our country. Yeah. We do verbal consent.
We obtain verbal consent.
Like, you agree. Yeah. And you also, and before you agree on something that you understand.
Exactly.
So like you are explained for, this is expected. Yeah. This and this is expected of you. Induction can take this long. Yeah. And then
it can even change. It can even fail.
It can even fail. Those are some of the things that you need to understand.
And in case it fails, what next? Or what is the alternative?
Very fast. Yeah. So that you don't also ignore. Yeah. And we miss the baby before. You're waiting for 8 hours for us
to come. And the baby is already here.
Within 3 hours, baby is born. Exactly. Because your bishop score was good. Yeah. Okay, ma'am. Yeah.
So, we were talking about, we've already obtained consent. Now, we need to empty our bladder. After emptying our bladder,
we insert this.
We insert the.
We are assuming we are using the.
We are using the pessary.
The pessary.
So, we have inserted, or the gel, the one that goes PV. So, after that, we are supposed to rest for like a period of 1 hour. Then, depending on the doctor's instruction, interval of 6 to 8 hours, no checking unless indicated. What do you mean unless indicated, Mary?
Unless the water breaks.
Thank you.
Unless the labor begins.
And it's very...
And now you're getting good contractions. And who defines the contraction? Is it the patient? You will say you're getting good contractions. Yeah. But it's the midwife or the doctor who
will tell if it's a strong or moderate contraction. Yeah. Because a moderate contraction may be a strong contraction too.
To you.
Exactly. Yeah.
So after that, if by the 6 hours or 8 hours, our cervix has shortened. Yeah. Has thinned. Yeah. But we are not having good contractions. Yeah. We can do what we call amniotomy. Yeah. We can break the water.
That is if the cervix is open.
That is if the cervix is open.
Yeah.
Thin.
Yeah. And soft.
Yeah. We can break the water.
Yeah.
And maybe you are open. Yeah. You are open maybe above 3 centimeters.
Exactly.
We break the water. If the cervix could be more than 4 centimeters and you're getting good contraction, we allow you to progress.
Because amniotomy, we said, is also a way of inducing. Now we have given you, we have given you the prostaglandin. You have opened, yes. Now we want to give you another way. We have done amniotomy. Before we even augment, it's good to give time.
It's good. Probably you're given an hour
or 2 to check if the labor will peak.
After 2 hours, after breaking of water, you again come and reassess.
Exactly.
We have moved to 6. Keep going.
Keep going.
Now, you are left on your own.
Because for you to get to 6 centimeters, meaning you are contracting.
You're getting
very well. Yeah.
If after 2 hours still you're not,
there's nothing,
there's no much change, then that is what people say it's very painful. The drip. Now we come up with oxytocin.
It's also a hormone.
Actually, the love hormone. So we come with that hormone.
Love hormone, which brings pain.
But you said eventually you love your baby.
Exactly. The outcome will be joyous.
So from there, now the labor kicks. That one, you'll hardly feel to get contractions unless there's something very abnormal. So the labor will keep, and then we keep monitoring you and the baby till the end.
Exactly.
The other one, if you didn't open, maybe the cervix is still very thick, still facing behind, we put another tablet.
At an interval of 6 to 8 hours, depending on the doctor. That's why we say it's a process. Don't be too much in a hurry, because...
And by the way, guys, let me tell you, if your cervix is soft, thin, and the water has been broken, you see, if it is soft and thin, that means stretching will be so easy. So even if we put the drip, it's not so painful. If you have had good preparation on your cervix, drip is never too painful.
What do you mean by good preparation?
What we are doing. What we are doing. Yes. Instead, I find you are 2, I break the water and I put the drip, and the cervix is tight. So the pain tend to concentrate so much on the abdomen because it's not getting an outlet. Like the outlet, the force is not we are not exploding, like we are not opening.
So guys, it is okay for both the patient, for both the mother and the care provider. It's good to know that induction needs time. It needs time.
Be patient.
Yes. And when you're patient, the outcome will be good. And that is what we are looking at as a midwives reality show. A good outcome is our joy. Yes. So guys, that was about induction of labor. Not unless there's something you need to add, Mary?
No. I hope now you'll be able to face induction with a lot of courage. And guys, remember, we always talk of your psyche. Your psyche. Don't listen to many people outside there. Go to the
professionals.
Professionals.
There's something I needed to add. You know, some people, some of our mothers, they have the ability to deliver normally, not normally, vaginally, but because of the fear of the induction of labor, they opt to do the surgery. Remember, surgeries are done with an indication. If you really don't have an indication and you can do the induction of labor,
we can do this.
We can do it. Feel encouraged.
Get the psych,
and then
the
go
psych
for
is
it.
key.
If
Go for it.
Done it. Why not you?
Psych is all what we ask. Remember, if you face induction with a lot of anxiety, chances of it failing is very high.
Because it's all from the head.
It's all from the head. When you're anxious, you produce a hormone called adrenaline. Adrenaline will suppress any other hormone. It's a flight hormone. Hey, things are bad. Let's not go into labor. Let's sleep. So, for you to have a successful induction, let's be
positive
and be positive, and you'll conquer. It's never so hard.
It's never that serious.
See you in the next
one,
then you come thanking us. Bye. Remember to subscribe.